Now we have discussed GERD. Let's discuss the most common complication of GERD, which is the esophageal strictures. First, let me remind you with the erosive esophagitis. It comprises 20% of the upper GI bleeding all over, and it's the most common cause of upper GI bleeding in elderly with cognitive impairment, and is always an etiology for iron deficiency anemia in all age groups. It's treated with PPI, and it ranges from just erosions to ulcers and to even strictures. Remember that 1 millimeter caliber of the esophagus or the equipment you are using in dilatation equals 3 French. Regarding the symptoms by diameter, usually if the lumen is 20 millimeters or more, there is no symptoms at all. The critical caliber is 12 millimeters and below, which will give you dysphagia to solids. In between, from 18 to 13 millimeters, there's a variable dysphagia. Strictures are either classified into simple or complex. The simple are usually related to reflux disease, while the complex might be related to extensive reflux disease or other etiologies like biliary esophagitis, cancer, eosinophilic esophagitis. The simple stricture usually is short, smooth, and straight, while the complex are usually long, narrow, and tortuous. Regarding the management, you can dilate the simple strictures with any equipment, but the wire-guided equipment are usually preferable, while the complex you only need to use the wire-guided dilators for the safety purposes. The rule of barium swallow here is to locate or define the location and extent of the stricture, specifically the proximal ones. Regarding the peptic strictures, which usually are simple, we said the etiology is 70% of the time is GERD related. Symptoms-wise, usually these patients do not complain of weight loss, but they usually have a progressive dysphagia for solids. Regarding the management and diagnosis and treatment, remember the critical caliber here is 12. This is your target to look for. If at any time the patients are asymptomatic, you shouldn't dilate at all. And no matter what the caliber is, you just use a PPI/PID. If they were symptomatic, you look for the caliber now through the AGD. If the lumen is 13 millimeters or more, you have a chance to start a trial of a PPI. If that fails, you go ahead and dilate the patient and keep him on or keep her on indefinite PPI treatment. If the stricture was 12 millimeters and less, you should dilate from the beginning and keep the patient on indefinite PPI. There are some talks about if these modalities fail, you might use intralesional triamcinolone injections. After you manage your patient, you need to avoid the precipitating factors, especially the drugs. The biphosphonates do really have an impact, and they cause the worsening of the stricturing disease. And anyway, aggressive PPI treatment decreases the need to repeat the dilatation by from 70% to 33%. Contraindication to esophageal dilatations are acute, incompletely healed esophageal perforation and potentially malignant stricture. The strictures that you need to dilate with extreme caution are strictures related to eosinophilic esophagitis mainly. Here are some types of different modalities and different dilators. Mechanical dilators mainly are stiff or hard equipment. We have three different types here. The one what we call it the non-guide wired assisted, which is the bougie dilators, the guide wire assisted Swaity dilators, and endoscopic overfit. The two we usually use are the bougie dilators and the Swaity dilators. The bougie are tapered tip that is filled with tungsten or mercury, and they are in different calibers. The Swaity dilators are a form of a vinyl and has a tapered end and comes in different dilator and need pre-warming before being used for dilation. The difference between the bougie and the Swaity is that the bougie dilators are non-guide wired. You might use a fluoroscopy with that or not. The Swaity is guide wired, and you might use a fluoroscopy with that. The other balloon, the other dilator are the balloon dilators, which have an equal radial force along the stricture length, and they are actually preferred for the longer strictures. There are two types. The TTS, which through the scope, it goes through the biopsy channel of the scope, and the other type is the over the guide wire. The balloons can expand to 3 different diameters, up to 1 or 1.5 millimeters increments. Actually, you need to be aware that these patients need to be off antiplatelets prior to the procedure. Precisely, we're talking about the clopidogrel, and you know now that there is no need to have any antibiotics prophylaxis before the procedure. When you start the dilatation, you need to have an estimate of the caliber of the stricture you're facing. The first, remember that we use the rule of 3 increments each session. That's the maximum number of dilators that you're gonna use. You cannot go beyond that. Remember that you have a critical number of only 2 millimeters of increment, which equal 6 French each session of dilation. So the point here is that the first dilator shall match the exact caliber of the existing stricture. So you don't need to count that as a dilatation. We give it here 0 millimeters. Then you go up with a higher caliber. Now you add 1 millimeter, which is 3 French. Then the last one will be another 1 millimeter, would equal another 3 French. Then you have total of 6 French per session. Then you need to stop. You don't go any further. The same rule apply for the balloon dilators with a maximal of 3 increments, 2 millimeters, 6 French. After a successful dilatation session, you repeat the dilatation after 5 to 7 days until sufficient progress is achieved. Usually with the successive session, you start with the last dilator you used, but that not really happens all the time. Sometimes you might need to restart from smaller size. Your endpoint of dilatation is the symptoms relief. Usually you're talking about 18 to 20 millimeters caliber. That would be sufficient and satisfactory. After you treat your patient with the dilatation, you need to place this patient on high-dose PPI at least for 1 year. You might even go up to 40 milligrams BID that have a proven decrease in the need of free dilatation in the future to less than 33%. And that's it for the dilatation for now. Let's go now with the esophageal anomalies. We will talk about the whips and the rings quickly. The esophageal whips are formed of one layer only. Usually they are thin, horizontal, and mainly formed of only one layer of squamous epithelium. And usually they occupy the upper part of the esophagus, the cervical region. Usually they are asymptomatic, and they are found in 10% of the people. The etiology here is variable, congenital to chronic graft-versus-host disease, Blammer-Vincent syndrome, and the esophageal whips do pose a risk for the squamous cell carcinoma. The barium swallow have a valuable diagnostic value here. And regarding the management, if the patient have a Blammer-Vincent syndrome, it's stated that the correction of the iron will help in resolution of the dysphagia. If that didn't work, you go ahead and dilate the patient. 3 types of rings we have: the A, the B, the C. The most important one is the B ring. Remember, the Germans type the S as a P as a pita. So remember, P is a S, so Swaity ring. Another hint here is called the stick house syndrome. The B ring or the Swaity ring is composed of 2 layers. A mucosa and submucosa, usually located at the demarcation of the squamous-columnar junction. It's usually thin, and there is an association with hiatal hernia. The etiology, they're not sure if it's congenital or acquired, but it's also related to GERD most of the time. And remember that there is a variation with the food impaction that happens being beef and pork is the worst, and chicken and fish is the least to give symptoms. Usually it's asymptomatic and non-progressive, and there is no weight loss. But again, it's related to meat and stick as a symptoms. Barium swallow also have a very good radiological diagnostic value. If the ring is asymptomatic, you don't need to treat it. If it's symptomatic, you go ahead and dilate and give a PPI. That will also decrease the need of redilatation in the future. If the dilatation didn't work, you can go ahead and use the electrocautery incisions and cut the rings. The C ring and the A ring, the C ring is related to diaphragmatic crura. It's rarely symptomatic and doesn't need any treatment. The A ring is formed of only muscular layer related to the muscularis propria, and it's usually located like 2 centimeters above the G junction. Rarely symptomatic and rarely needs a treatment or dilatation at all. In the next video, I will discuss with you the hiatal hernia, the inlet patch, and the fibrovascular polyp.